Hello, welcome back to Healthcare Policies for Asbuca and Rise Early Education Academy. Um, we are on page 14 and we're talking about medication administration, medication given to children at our center. Only trained personnel are allowed to administer medication. The training for medication administration must be renewed annually. There must be one person trained in the implementation of a child's IHCP whenever the child is in the care of the program. In addition to a licensed healthcare practitioner, training to implement an IHCP may also be given by the child's parent or the program's healthcare consultant with the licensed healthcare practitioner's written consent. The parent must fill out the authorization for medication form before the medication can be administered. And a parent's signed consent for medication administration will be maintained in the child's record in the files in the file cabinet. This consent form must be updated annually. A picture of the child should be stapled to the medication log as well as to the IHCP. All medication administered to a child, including but not limited to oral or topical medications of any kind, either prescription or non-prescription, must be provided by the child's parents or with a written consent can be provided by us. A child's parents will be notified at the end of each day whether a topical medication is applied. A written parental consent and authorization of a licensed healthcare practitioner needed to write and implement an individual healthcare plan that permits older school-age children to carry their own inhalers and epinephrine autoinjectors and use them as needed without the direct supervision of an educator. That's for the school-age program. Unless otherwise specified in a child's individual health care plan, we will store all medications out of the reach of children and under proper conditions for sanitation, preservation, security, and safety. Emergency medications, whether they are inhalers or EpiPens, will be placed in a clear Ziploc bag and pinned on the wall out of the children's reach, but easily accessible in emergency. Currently, we have one student with an EpiPen. The medication is in a Ziploc bag, zipped, labeled, and with the appropriate documentation, and it's located in the preschool child's backpack. That way, instead of being pinned on the wall, it's away, it's in the backpack, and when we go to the playground, we have it with us. Or if we have any field trips or any other emergencies, the backpack goes with us. So all medication administered to a child must be in the container in which they were originally dispensed and with their original labels affixed and include the child's name, the name of the medication, the dosage, the number of times per, and the number of days the medication is to be administered. The prescription label will be accepted as the written authorization of the physician. This is very important. We cannot receive and keep any medication without being in its original box with the prescription label on it. The center will not administer any medication contrary to the directions on the label unless the authorized by written order of the child's physician. Over-the-counter medications must be in the original manufacturer's packaging. The educator must not administer any medication contrary to the directions on the original container, unless so authorized in writing by the child's licensed healthcare practitioner. Non-prescription medication will be given only with written consent of the child's physician. The center will accept, that doesn't make sense. The center will accept a signed statement from the physician listing the medications, the dosage, and criteria for its administration. This statement will be valid for 1 year from the date that it was signed. So in other words, if a child is given any like Tylenol or Advil or child's medication, we need a consent from the child's physician to do this. And again, this consent will be for 1 year. Along with the written consent of the physician, the center will also need written parental authorization. A parent must fill out the authorization for medication form, which allows the center to administer the non-prescription medication in accordance with the written order of the physician. The statement will be valid for 1 year from the date it was signed. Any medications without clear instructions on the container must be administered in accordance with a written physician or pharmacist's descriptive order. The center will make every attempt to contact the parent prior to the child receiving the non-prescription medication unless the child needs medication urgently or when contacting the parent will delay appropriate care unreasonably. For example, if a child has conjunctivitis in his eyes and he has to have a 10-day, 3 days, 3 times a day medication, after a few days when it's non-allergic, a physician can, with a physician note and the parental consent, we can give the medication to the child if it's packaged correctly and with all the documents corrected. Topical ointments and sprays. A topical ointment and sprays such as petroleum jelly, sunscreen, and bug spray will be administered to the child with written parental permission. The signed statement from the parent will be valid for 1 year and include a list of topical non-prescription medications. In the enrollment forms, there is a spot where the parent signs for non-prescription medication. At times, they write in the medication that they will accept for their child, skin sunblock or petroleum jelly or bug spray, and they will give an open permission for us to give them the medication. When topical ointments and sprays are applied to wounds, rashes, or broken skin, the center will follow its written procedure for non-prescription medication, which includes the written order of the physician, which is valid for 1 year, and the authorization for medication form signed by the parent. Each time medication is administered, we will document in the child's record the name of the medication, the dosage, time, and method of administration, and the name of person who administered the medication on the medication administration record form. No educator shall administer the first dose of any medication to a child, except under extraordinary circumstances and with parental consent. A separate medication log for each medication that each child takes will be used. Every entry in the medication log should be completed in ink and dated. If the child refuses the medication or if it gets spilled, a note will be made about what happened on the medication log. Record in the log if a partial dose is given. If the medication is not given because the child is absent, mark the absence on the medication log. Reactions and side effects should also be listed. For example, if the child vomits after taking the medication, that should be listed. The educator will use the 5 rights method to administer the medication. Number 1, number 2, number 3, number 4, number 5 starts with the right one. Right, number 1, the right medication. Number 2, the right child. Number 3, the right time of day. Number 4, the right dose. And number 5, the right route or way of giving the medication. So the 5 right ways are checked each time we give medication. If a medication mistake or unintentional poisoning does occur, we will call the local poison center immediately at 1-800-222-1222. That number should be in your cell phone also, just for emergency purposes. Multiple medications for the same child will be kept together in their original containers inside a bag or of the storage container with the child's name clearly visible. The medication bag or other storage container will include a photo of the child. That way you can check right child, right medication, right time, the right dose, and the right way to give that dose. Medications for potentially life-threatening conditions, such as inhalers or EpiPens, will be stored so that they are immediately accessible. Remember, the EpiPen for our child right now is where? In the preschool backpack. That's the emergency backpack that's hanging on the wall as you enter the classroom. When possible, all unused, discontinued, and outdated prescription medications will be returned to the parent, and the return will be documented in the child's record. When return is not possible or practical, such prescription medications will be destroyed and recorded by a manager or supervisor in accordance with the policies of the licensee and the Department of Public Health Drug Control Program. Omissions and errors. If a child does not receive his or her medication or receives the wrong dose, this is considered a medication error. In the event of a medication error, follow the steps 1, 2, 3. Number 1, circle the time the medication was to be given or the dose that should have been given. Number 2, explain why the medication was not given or was given incorrectly in the comment section and include your signature. Number 3, complete an incident report and contact EEC if the missed dose results in hospitalization or an emergency treatment. Possible adverse reactions. If the following symptoms in a child who is taking medication are noticed, the information about reaction will be documented, and the instructions provided by the healthcare professional will be followed. So, the symptoms could be difficulty breathing, rashes, drowsiness or confusion, nausea and or vomiting, headaches, muscle weakness, severe stomach cramps, or diarrhea. Asthma is a common lung disease that affects many children. Know your students' asthma triggers and closely follow their healthcare professional's asthma action plan in order to prevent and manage flare-ups. This healthcare professional's asthma action plan is typically included with the IHCP, and it's usually in a visual description as pictures and things to do in case of a flare-up. And a flare-ups might include wheezing, coughing, tightness of the chest, or shortness of breath. If you observe any unusual behaviors or if the child complains of unusual symptoms or symptoms described on the medication label, check with the child's healthcare professional. If you observe serious adverse reactions, who do we call? 911. If any of the following symptoms occur, or what we just talked about, parents will be notified immediately and asked to pick up the child from the program. So, a plan for meeting individual children's specific health needs. We're looking at food safety, allergy prevention, plan for infection control. Those are the three we're looking at right now. So, food safety, as educators, safeguarding children's well-being is paramount. We must be vigilant about food allergies and potential choking hazards. Carrying hot drinks through play areas should be avoided, and hot beverages are always kept out of the reach of children. We do allow coffee and tea in the classroom, but again, be sure that the hot beverage is kept in a specific area on top of the bookcase, bookshelves, so children can't reach them. It's crucial for employees responsible for assisting children during meals to adhere to parents' or physicians' instructions when preparing and feeding special diets. Additionally, they should follow parental guidance and any directions provided by the child's physician regarding food allergies. Safety and communication are key in assuring the well-being of the children. Ensuring children's safety during meals is crucial. Here are the key policies to follow. Number 1, supervision by trained staff. A trained staff member, such as a teacher, assistant teacher, or director, should always be present when children are eating. Staff members must be attentive to any changes in the child's behavior or well-being during meal times. Number 2, no not walking with food and drinks. Children should not walk around with food or drinks. This prevents accidents and choking. Encourage each child to sit and eat in a designated area. This has to be monitored. In our classroom and other classrooms, I know children walk around. At homes, they wander around eating their food. This is something that they do. But at school, they don't do this, not here at Rise. We need to prevent accidents and prevent choking. Therefore, they sit while they eat. And as soon as they finish, then they can clean up, wash hands, and come back and play. Allergy prevention. During intake, parents will be asked to provide a list of known allergies. This is on the enrollment form, and we have a special section for their known allergies. The information will be updated yearly, and then there is a sign on the wall that says known allergies for each child. Please be aware of this, and the sign on the wall is located in both classrooms. The preschool classroom over by the Art Center with all the other documents on the wall, and in the second classroom, you go into the classroom, and on the left-hand side, that document is right there. Allergy prevention. Ensuring food allergy prevention is crucial for the safety and well-being of the child. So read food labels. Always read food labels for all products brought into the program. This includes foods from children's lunches and snacks. Avoid serving any food that lacks clear ingredient labeling, especially if a child has allergies. Communicate allergen-safe policies. Ensure that the allergen-safe policy is effectively communicated to all parents and staff. Visitors to the program, even during off hours, should also adhere to these policies. All staff and substitutes will be kept informed by the program director so that the children can be protected from exposure to foods, chemicals, pets, or other materials to which they are allergic. Hand washing. Staff members should wash their hands before and after assisting children during meals. Hand washing is especially important after handling any food containing allergens. Number 4, avoid unintentional contamination. Take special precautions when handling food to prevent unintentional contamination. Use designated dishes and serving utensils to avoid cross contact. Prevent food sharing. Encourage children not to share food. This minimizes the risk of exposure to allergens. Number 6, awareness during activities. Be mindful of food allergies when cooking with children or engaging in activities like math or art using food. Number 7, field trips. Plan field trips carefully to avoid allergen exposure. Contact the destination ahead to ensure they can accommodate severe food allergies. Even while we're at the playground, please be aware of what our environment and what foods are where. This will help to prevent any allergen exposure. Symptoms and emergency response. Any symptoms after eating may indicate a food allergy. Treat every symptom as critical and seek emergency medical attention. Notify parents and guardians promptly. Epinephrine, EpiPens. Each child with food allergens should have 2 EpiPens provided by the parents. Administer epinephrine immediately if prescribed and signs of an allergic reaction appear. Staff members are trained in EpiPen use by either the parent or our healthcare practitioner. Individual healthcare plans. Document training and administration directions on the child's IHCP. Older school-age children may carry their own inhalers and EpiPens as needed. Medication expiration. Medication must be replaced when it expires to ensure effectiveness. Allergy information. Each child's allergies will be prominently posted in the classroom or wherever food is served. Allergens list will be updated as necessary. When new children enroll, unknown allergies become known. The names of children with allergies that may be life-threatening, like bee stings, will be posted in conspicuous locations with specific instructions if an occurrence were to happen. The program director will be responsible for making sure that the staff receives appropriate training to handle emergency allergic reactions. Confidentiality of allergy information is crucial. I just need a sip of water.
Conspicuous.
Water break. All done. Warning signs of allergens. Visual signs indicating allergens should be posted on the wall in the hall, in the class, or in the classrooms. Required postings. An easily visible area we have is a list of emergencies or life-saving medications, the EpiPens or the autoinjectors or the inhalers, and their assigned children, and allergies and other emergency medical information provided by parents in each child. So, plan for infection control. The program director shall ensure that staff and children wash their hands with liquid soap and running water using friction. Hands shall be dried with individual or disposable towels. Staff and children shall wash their hands minimally at the following times: before and after eating, before and after handling food, after toileting, after coming into contact with bodily fluids and discharges, after handling center animals or their equipment, after cleaning. The program director or lead teacher shall ensure that the specific equipment, items, and surfaces are washed with soap and water and disinfected with a fresh standard bleach solution, 1/4 teaspoon per 1 quart, or other EPA registered product using the following schedule. All right, so we're going to go through after each use, at least daily, and then at least monthly or more frequently. So again, items are washed with soap and water, disinfected with a fresh standard bleach solution. After each use, sinks and faucets used for hand washing after the sink is used, for rinsing a toilet training chair. Me specifically, I throw that into the toilet, the pee. Toys mouthed by children, mops used for cleaning bodily fluids, and thermometers. You can use a sheath over the thermometer if it's put into the mouth, but still be sure to wash it. At least daily, toilets and toilet seats, sinks and sink faucets, drinking fountains, water table and water play equipment, play tables, smooth surfaced non-porous floors, mop used for cleaning, and washcloths and towels. And monthly, at least monthly or more frequently as needed to maintain cleanliness when wet or soiled and before use by another child, cots, mats, and other approved sleeping equipment. Each child has a cot with their name on it, and each child has a sleeping bag with their name on it that they put on top of the cot. The sleeping bags are sent home the end of each week for the parent to wash. Sheets, blankets, and other coverings, and machine washable fabric toys. So those are at least monthly or more frequently as we see them being wet or soiled. All staff should wear gloves, non-latex gloves, when they come into contact with blood or body fluids. Specifically, gloves should be worn during diapering, toileting, when administering first aid for a cut, bleeding wound, or bloody nose, or when feeding an infant breast milk. Hi, I'm back. Gloves should never be reused, and they should be changed between children being handled. Proper disposal of infectious materials is required. Any disposable materials that contain liquid, semi-liquid, or dry caked blood will need to be disposed of in the secured trash receptacle located in the janitor's closet and marked biohazardous waste. The bag should be removed and securely tied each time the receptacle is emptied. Cloth items that come into contact with blood or bodily fluids will be double bagged and sent home. Each staff member will be trained in the above infection control procedures upon employment and before working with the children, and then annually. And the infection control procedures are in the EEC Essentials 2.0. The EEC Essentials 2.0 is required during orientation of a staff member that starts and annually. There's a refresher course now available for EEC Essentials 2.0. Okay, procedures for using and maintaining first aid equipment. Location of the first aid kit. Each classroom has a first aid kit. Its location is marked by a red cross contacted on the front of the container. The first aid kits are stored out of the reach of children but easily accessible in case of an emergency. Let's see. Portable first aid kits or the emergency backpack include first aid supplies, children's emergency contact information, and telephone numbers. We bring this emergency backpack on walks to the playground at all times, or if we do any fire drills or have to leave the building in case of an emergency. The portable first aid kits are in Classroom 2, which is the preschool classroom. Walk into the classroom, look to your left. Above the cots on the wall, there's a little kit there. You can use that one. And also right there is a thermometer. And in Classroom 1 with the school-age children, you go into the classroom, you see the bookcase full of games and puzzles. Up on top, there's a big white metal box with a red cross on it. That's the medical kit in addition. So we can use either one for whoever needs it. Who maintains the first aid kit? I do. The first aid kit is kept supplied by the program director. First aid kits will be inspected monthly, but supplies will be replaced as needed. So let me know if you use anything out of the first aid kits, and then we can restock it. Staff should report missing items to the program director. If there are any missing items, you're looking for something, let me know. We either have it stocked or need to go buy it. Staff certified in first aid in accordance with recommended procedures will use all first aid supplies and/or equipment. All staff must be first aid certified within 6 months of employment. One staff member certified in CPR must be on premises during all hours of operation. So, contents of the first aid kit include Band-Aids, gauze pads, adhesive tape, disposable non-latex gloves, gauze roller bandage, instant cold packs, tweezers, scissors, and thermometer compresses. That's it. Mandatory reporting. This is the last subject in our health policies. I'm going to review mandatory reporting and what that is and how to do it. But there will be a separate training on this subject because I know that it's intimidating or we hesitate to report. And there's a huge form, a very long form, a lengthy form that we need to fill out to report. So in the next training, we're going to go over a form to fill out to report an abuse or neglect. So according to Mass Department of Early Education and Care Regulations 2010-606 CMR 7.114 D and E, every educator is a mandated reporter under MGLC 119, paragraph 51A, and must make a report to the Department of Children and Families, DCF, whenever he or she has reasonable cause to believe a child in the program is suffering from serious physical or emotional injury resulting from abuse inflicted upon the child, including but not limited to sexual abuse or from neglect, including but not limited to malnutrition, no matter where the abuse or neglect may have occurred and by whom it was inflicted. The educator must notify EEC immediately after filing or learning that a 51A report, the 51A is the report, the lengthy report that we will at one point review, has been filed alleging abuse or neglect of a child while in the care of the program or during a program-related activity. The Child at Risk Hotline is 1-800-792-5200. All mandated reporters are required by law to mail or fax a written report to the Department of Children and Families within 48 hours of making the oral report. The following procedure will be followed. Number 1, a staff member who suspects abuse or neglect must document her observations, including the child's name, date, time, child's injuries, child's behavior, and any other pertinent information. Staff member will discuss this information with the program director. And number 2, the program director or the staff member with the assistance of the program director will make a verbal report to DCF to be followed up by a required written report, the 51A, within 48 hours. The DCF phone number is the Department of Children and Families. Phone number is 617-748-2000. They're open 8:45 to 5 p.m. Monday through Friday. Number 3, if a staff member feels that an incident should be reported to DCF and the program director disagrees, the staff member may report to DCF directly. 4, all concerns of suspected abuse and neglect that are reported to DCF will be communicated to the parents by the program director unless such a report is contraindicated. Procedure for identifying and reporting child abuse, neglect while in the care of the center. It is the center's commitment to protect all children in care from abuse and neglect. The following are procedures for reporting suspected child abuse, neglect while the child is in the center's care. Any report of suspected abuse and neglect of a child or neglect of a child will be immediately reported to the Department of Children and Families and the Department of Early Education and Care. A meeting will be held with the staff member in question to inform him or her of the filed report. The staff member in question will be immediately suspended from the program, with pay pending the outcome of the DCF and EEC investigations. This is if they're a full-time employee. Salary, not hourly. If the report is screened out by DCF, the program director has the option of having the staff member remain on suspension pending the EEC investigation or allowing the staff member to return to the classroom. This decision will be made by the program director and will be based on the seriousness of the allegations and the facts available. If the allegations of abuse and neglect are substantiated, it will be the decision of the program director whether or not the staff member will be reinstated. The program director and the staff will cooperate fully with all investigations. Again, we'll go over that mandatory reporting and how we report and the 51A at a different training. I hope you all have enjoyed this training. There are 4 videos to watch. Start with number 1, 2, 3, and then 4. Be sure to fill out the self-assessment before you take this. I suppose I should have said that at the beginning, and maybe I did. And after you finish this, take the self-assessment, see what you've learned. If you have any questions, ask myself or Natalia, and we will be happy to answer it. Thank you for working for us. Take care.